part here. We have to see the see this part here, and down here external part. So this is the extrathoracic part, and a bit of part from the abdomen that also comes in the X-ray. So sometimes the accidental finding can be seen here, even if we are trying to look at the thorax. So then in intrathoracic part here, we can easily see this is trachea, this is carina, that is where the bifurcation starts for the main bronchus. And if you can really appreciate this is tubular structure here. So this is the aorta, okay? This is the diaphragm, this is the left part, and this is the right part, and this is the dome of the diaphragm. So this structure we really need to keep in our mind. This is the normal structure of the thorax, thoracic cavity. And here, down here, this is the heart, okay? This is the cardiac structure. And right here, we can see this is the caudal vena cava. It may not be visible clearly in all the radiographs, but at least if we know the location, that is good for us. And this is the sternum part. And right here, what I want you all to understand is, we are looking at this image. Normally, then we just see there is a black area and there is a white area of heart and this aorta and all. But if we really look deep, then we can really understand there is a lot of vessels going around. So if we can see here, there is vessel and there is a branch here, small branch, here small branch, and right here, if we see, this is the vessel, okay, and down here, this is also the vessel, and towards the periphery, you can see the branch. So these are the normal vessels supplying the lung tissue. Right here, this is also vessel, okay, and right here, this is also vessel. This is getting more branch when it's going towards the periphery of the lung tissue. So these are the vessels we really need to understand. If these vessels are really clear, it's clearly visible, then chances of having some pathological condition, like we can say this is a normal vessel supply in the lungs. Now, what we need to understand is, this is one vessel on the dorsal part, this is another vessel on the ventral part. And the part between the vessels, this is the bronchus. So this is the bronchus supply. Here also this is the vessel, and down here this is also the vessel, and this is the bronchus supply. So now what we have to understand, if we really need to go in deep, first dorsal comes artery supply and the bronchus and the vein. So we can say A, B and V, artery, bronchus and vein. So these are the normal pattern of the supply that happens in the lung tissue. Once we start understanding this minor structure, then it's very easy to understand the pathological condition. I hope it's visible and everyone is able to see. Now let's go further, and this is the another view. This is the ventrodorsal view, and right here in top you can see the cranial mediastinum, and this is the aorta, and this is the heart. I hope this is better, and this is the structure, and this is the diaphragm. So this is the normal structure of the lung, radiographic structure when we see ventrodorsal view. Now let's talk about the lung lobe. So here I have just put some marking how it supplies. So this is right here. This is the cranial margin of the right cranial lung lobe, and this is the caudal margin of the right middle lung lobe that we can really appreciate. But it is not visible in normal normal condition. So it is only we may be able to appreciate when there is some pathological condition. And this is the margin of accessory lung lobe. And this is another view. So right here, This is the border between the cranial and caudal left lung lobe, and this is the caudal margin of the left cranial lung lobe. So right here again we can see. So I just want everyone to try to see the minor structures. Right here we can see aorta. This is a caudal vena cava. This is the diaphragm, and right here again you can see this is the supply of vessels. There is one, and another one is down there, and in between that there is a bronchus. So artery supply, bronchus, and venous supply. So this is how it has a supply.
Full screen
Full screen ma यो आउँदैन डाक्टर साहब यो
आउँदैन ल
यो क्रसअप नआउने भएको भएर मैले गरेको
जुम इन गर्न मिल्छ कि
ओके
स्पेशल त्यहाँबाट त्यो बेलामा मात्र
okay so now we can really see here, this is the supply and another supply is here. This is the supply of the cranial lung lobe, cranial part of the lung lobe, and right here if you see really minute, even this is a heart, you can see the supply here. This is here branching here, this is the supply branch is coming here, and again this is the supply here branch here. So you just need to see in very minute level. Even here there is all the supply of the vessel, so it's like the three branches going outward. So if we see like this structure, this we call the healthy parenchymal structure of the lung. So now after understanding this, let's move forward to the another view. So here this is the right cranial lung lobe, and margin will be here. It's right middle lung lobe, margin will be here, and this is the right caudal, and this is the margin with the accessory lung lobe will stay here. And this is normally we according to the supply we divide right lung lobe in cranial, middle, and caudal. Cranial, middle, and caudal, but the left lung lobe will be divided in cranial. This up to here is cranial, and this is the cranial part of the cranial lung lobe, and this is the caudal part of the cranial lung lobe, and this is the caudal lung lobe. So this division is based on the supply, not the lobe. So accessory lung lobe will stay here. So this is, we don't need to worry much about this location. We can find anytime, anywhere this reference. But let's try to understand. And this is the heart, and this is the mediastinal area right here. And it will, mediastinum runs all the way from the cranial to the caudal. So right here, if you see, this area is the mediastinal area. So this is how, because mediastinum is not like visible how we think. It is there where this all the extra pulmonary structure stays in the mediastinum. Like the lung lobe, other than the lung lobe, everything will in between stays within the mediastinum. So that runs through the mediastinum. Now let's understand about the heart and how it looks. So if we take the X-ray of the lung in lateral projection, so this will be the chamber positioning. So right atrium, right ventricle, left ventricle, and again this is the aorta, this is the caudal vena cava. We can clearly see. I hope it's visible. So here there is one margin, another margin is down here, and this is the aorta, and right, left. So this is how always in lateral projection, right atrium will be at the front in the cranial in the area, and the left will be in the caudal area. So right, left, right, left. So this is how we have to try to understand. And in the ventrodorsal view, this is the shape of the heart normally we see. Like it's like little bit of bulging here, and it comes like a in this area, and this part is a little flat. So sometimes if we see the enlargement of the left atrium, then this area may look little bulged. So this is the actually normal shape of the heart that we see in radiograph in ventrodorsal. So this is the right part, this is the left part. So this area, left atrium, this is the right atrium and right side, this is left ventricle, and this is right ventricle, this is left ventricle, and down there this is diaphragm. So this is the normal structure. I hope everyone we know, but we have to see a little bit in detail to understand more. So even in this picture, we can see the supply here. Let's go all the branching towards the periphery. So after understanding this, let's go a little bit into the interpretation. So this is the normal structure. So first we have to understand, at least we have to understand, let's go in the first picture, at least we have to understand the trachea. It's right here. This is the cardiac structure right here. This is the diaphragm right here. And this is the aorta, caudal vena cava, and the vessel supply. Vessel supply right here. Here. So we may not see this vessel supply clearly in all normal cases, but if there is a proper positioning and proper exposure, then it's very easy to appreciate all those supplies. So now let's go into the interpretation. So before going to interpretation, we have to understand the 4 compartments of the, as we already discussed, the chest. So first is extrathoracic structure, and then the pleural space, pulmonary parenchyma, and the mediastinum. So extrathoracic structure, it's not that difficult to understand. All the parts, bones and muscles, and everything that stays outside of the thorax, that we consider extrathoracic structure. Why I'm stressing this? Because it may not be helpful for the thoracic diagnosis, but sometimes we may find accidental finding, like sometimes there may be some abnormality with these bones right here, sometimes in this area, sometimes this area. So even if we are taking chest x-ray, we shouldn't miss out the other information that is outside of the chest. Now the next is pleural space. So before going here, let's understand. So the pleural space should not be seen on thoracic image from normal animals. So normally it is not visible because this is the very small space that is in between the lung lobes and the thoracic wall. Again, if we can see very minutely here between the lung lobe and the thoracic wall, there is a thin layer, but it is folded. So if there is a minor fluid contains, then sometimes it's easily visible. Now we can say yes, but sometimes even if we don't see, it's normal. Even if we see, it may be normal, but it depends upon the fluid content between the pleural space. So there is a 2 lining. Between the lung lobe and the thoracic wall, there is a pleural space, but it is not the one thin layer. It is a folded 2 line. So there is a cavity within the pleural space. So anything builds up, it may get collected within the pleural space. In that case, only pleural space is visible. Otherwise, it's not really visible. So if you need to understand the pulmonary parenchyma, we really need to, again, I request everyone to see the image again and again in really in detail. So even here, we can see the vessel supply. You can see this is the vessel. We can see the branching here. We can see the branch here. Even here also, this is one supply, this is another supply. Right up here, this is one supply, another supply. So overall, if we talk about the pulmonary parenchyma, this all the lung tissue that what we see here, that it means pulmonary parenchyma. And other than that, there is a vessel supply. there is a heart sitting right at the middle. So in this regard, we really need to see everything in detail. Now, mediastinum is right here. We already discussed. This is mediastinum, this area. And mediastinum doesn't mean that we see mediastinum. It is the place where all the extra pulmonary structure stays in the between of the lungs. So it is the space actually. So it's not necessary that if we say mediastinum, we will see mediastinum. It is the space there where this heart stays, this area, upper area where the trachea and everything, this supply, this part, at least we need to understand right here. This is the margin of the mediastinum, and right here this is also the margin of mediastinum that we can clearly see. Again, down here also it always runs from cranial to caudal, and all the other organs other than the lung tissue stays in the middle within the mediastinum. So before going to further interpretation, we really need to understand some basic principle of interpretation. So most important things are positioning, exposure, views, and labeling. So these things we always need to understand. Otherwise, sometimes some mistakes can happen. Even like I'm stressing more on labeling, because if we don't label the X-ray properly, even if we send that X-ray to another person for evaluation, misinformation can come. So always we have to label left, right, which view. It is very important. So first, let's discuss about the positioning. The proper positioning is really, really helpful. Now I have these slides. It's a little bit interactive slides. I don't know how we can interact here. So this is the image. This is the A and B. Both are the two different images, but it is from the same dog. This image was exposed at the same time, maybe one first and the second later. But again, there is a huge difference in the X-ray. So I don't know if we can interact with the text or anything here. Can we?
Yes, we can.
So can anyone just write down here so that at least I know we are interacting? Why these two images are different? So, because this is from the same dog. Image A is an image B from the same dog, but it is different, right? We can see clearly there is a difference in the X-ray image. Yeah, it's about positioning, but what may be? I can see two text. This is saying the position, but what position? So it is because in X-ray A, the head of the dog is flexed, right? It is bent down, more ventral. In B, the head of the dog is extended. So that is the reason why this looks different. So here, That's why we can see here we can easily see the trachea has bent right here, and the position is like this. It's because the neck is flexed downward, and in this image you can see the trachea is straight. So it's just the differences in one exposure. There is a head moved upward, and one exposure head moved down. So you can see such a difference. So you have to really understand, because the positioning is really important. Now we have to understand the exposure. Definitely, it's all about the taking X-ray. So here, I mean, I'll be happy if you all can text saying what is this image, either proper exposure, underexposed, or overexposed. There is something. I mean, it's either one. So yeah, it's definitely. So yes. So if X-ray, we can see it's more towards the black, so it's overexposed. I'm happy to see all those comments. And now let's move to the next. So definitely we can say this is underexposed, and now we can say this image is proper exposure. Now we can clearly see. If we see here, we can't see the whole thoracic. A little bit of heart area is visible. Here we cannot see properly. This is exposed. Now it should look like this. Now again, I'll be stressing more on the blood vessel supply all the time. I hope you won't get irritated, but this is very important. So now again, try to see the vessel supply in this image. It's really nice. It's a beautiful vessel supply we can see. Now X-ray image of the same dog, why it looks different? It's the same dog taken within 5 minutes. What may be the reason? Because this is really important. Sometimes if we don't correct our exposure technique, sometimes we'll get misguided. So yes, this is the right that is in the front, and these two images, one with the inflated lungs, one X-ray, and another X-ray without inflation. So if it is possible, it's always better to take the X-ray with the inflated lungs. So I hope we already discussed this. This is also the image of the same dog, but in different situation. One is inhalation, complete, fully extended lungs. Another one is after exhalation. So now another thing we have to understand, that at least two views we have to consider while taking the thoracic X-ray. 3 views are preferred. In lung tumors also, sometimes, because there may be also collection of the fluid and some lung tissue collapse, that is the localized. And in generalized, severe bronchopneumonia, even edema, hemorrhage. In case of drowning also we see that, because the animal gets aspirated, and smoke inhalation and acute respiratory distress syndrome. These are the conditions we see alveolar pattern. Now the next is bronchial pattern. So this is also really important. So it is bronchial pattern is generally generalized, and bronchial pattern means now the bronchus is affected. Alveolar means alveolus is affected. Now if the bronchus is affected, bronchus means it's a supply of the the air tract. Now, if it gets affected, that means only bronchus gets either inflamed or there is a pathological changes. So if there is a pathological changes in the bronchus, then definitely we'll see some changes in the bronchus. So now this may be sometimes minor changes. If we look here, right here, and if we look here, this is the magnifying part. If we look here, there is a circle. That means inside there is air, and outside there is a bronchus wall is looking more opaque, right? More opacity of the wall because it is affected, like the inflammation or some disease process. The wall looks more dense when there is a change in the bronchus. Now, if we really see minutely, we can really see the ring that we call the Dunot's. And the tram line, we call the tram line. If this bronchus gets exposed in longitudinal view, then it looks like a track. If it gets exposed in transverse view, it looks like a donuts, a ring. This, like here is a ring structure, and here also is a ring structure. For the bronchial pattern, we really need to look in minute way. Then definitely we will see. Now, if you look here, and if you go back here, now again here you can easily see where are the donuts patterns, right here, right here, right here. So this is called the bronchial pattern, and so this is more prominent in the center rather than the periphery. So this peripheral bronchus supply may not have this. Mostly we see this bronchial pattern in this region, the central region of the lungs, like soon after. Azur?
Magnify नगरेसम्म त्यो डोनट प्याटर्न अथवा रिङ शेप देखिरहेको छ
यसमा त म्याग्निफाई छ नि हैन यसमा म्याग्निफाई छ यहाँनिर रिङ देखिरहेछ हैन
देखियो सर
अब we can compare in both. See this one and this one. So mostly this pattern, as I just said, this is more prominent in central supply, not the peripheral supply. So bronchial pattern, we really need to look in central supply. So here you can see, just try to see the donuts. So now let's understand bronchial pattern, because this bronchial pattern, the alveolar and the interstitial pattern may have very vague possibilities, but bronchial pattern is very specific most of the time. If we see bronchial pattern in cat, number one diagnosis will be feline asthma. Mostly this is really common finding. And in case of allergic bronchitis also, we'll see the bronchial pattern. And sometimes if there is a parasitic infiltration, that is also we see bronchial pattern. This is in chronic situation, and sometimes even edema we may see. But mostly this is really helpful in case of dog. If there is a kennel cough, this is very evident in dogs. And in cats, in case of feline asthma, this is very evident. So if we see this, then we have to think about, if we see this pattern in cats, we have to think about treating them for the feline asthma. If other conditions, if we can rule out properly. So this is really easy to rule out the bronchial pattern if we really need to, if we really try to see in very minute way. Now let's move to interstitial structure, structured and unstructured pattern. So this is now we discuss about the bronchus, because there is a problem with bronchus, we saw bronchial pattern. There is a problem with alveolus, we saw alveolar pattern. Now there is another part in lung tissue other than bronchus and alveolus is the interstitium. So if there is an issue with interstitium, we will see interstitial pattern. That is the tissue that makes a lung structure. So normally we say structure and unstructured. So actually it is again the same like alveolar pattern. It is increase in opacity. If we don't know what pattern, we can say increase opacity of the parenchyma. That may be any pattern. So again, same like alveolar pattern. Here, the tissue, the parenchymal opacity is increased, but one striking thing what we need to look for is if there is a, excuse me, if there is a alveolar pattern, we won't see vessel. Like we have been talking about vessel supply from the beginning, we won't see vessel in the alveolar pattern. But if there is an interstitial pattern, we will be able to see the vessel because the interstitium is affected, alveolus is not affected. So here also, this is the interstitial pattern. This is also interstitial. Right here, this is more structure. We have seen this nodular structure right here. Right here, this is the nodule. Right here, this is the nodular structure. And down here, this is more like unstructured, what we call. This is more white right here. But again, if we try to look more minutely, we can see the blood supply right here. One blood supply. One right here, another blood supply. And in between there is a bronchus. And here also, this is a supply. This is another supply. So basically in interstitial pattern, it's almost the same like alveolar. That means the increased opacity, not like a bronchial, that is more of the bronchus. But here, the vessel architecture is not disturbed. So but in alveolar, vessel is not seen. So this is two structures, structured and unstructured. Structured means the nodular, and unstructured means this is a generalized pattern. Now there is a different situation. Sometimes lymphoma, and even in obese dog. Sometimes if we have taken the X-ray of very obese dog, the parenchymal pulmonary opacity may be increased, but that may not be related with the disease. Sometimes the hemorrhage, even in case of hemorrhage, we can see that case of embolism and foreign body. And this is normally unstructured, and structured means more like nodular pattern. So that may be related with some fungal issue. Sometimes one very interesting, sometimes the nipples also can look like a artifact, and it is the outside of the thoracic cavity, but it looks like there is a growth inside the chest cavity. So we have to consider that also, thoracic wall artifact. And lung tumor, definitely. If we see nodular structure, first thing we consider may be the lung tumor, and some granulomatous conditions like a heartome, sometimes foreign body, sometimes hematoma, and abscess, even in the cyst condition, because these are more structured pattern. So they come with some margin, structured margin. So other mostly structured pattern is nodular pattern. Nodular can be anything: abscess, cyst, neoplastic condition, even fungal granuloma, and other condition that cause the granulomatous condition in the lung tissue. So this we call the structured interstitial pattern. Now another is vascular pattern. That means the veins are more engorged, either artery, vein, or both. So if we see right here, I hope it's visible. It's visible, right? So here, this is the supply. This is the artery supply, and this is the bronchus and the vein. So you can see it's really enlarged. The vessels are enlarged. So this is called the vascular pattern. I hope everyone is not sleepy. So, Sunirasa.
Yes, sir. Yes, sir. Yes, sir.
So let's have some case discussion. देखिरहेछ है यो पनि?
हजुर सर.
Okay, so let's discuss about one case. So whatever I ask, I suggest to send me a text. I can easily see the text from my another device. So there is one dog, 9 years old, mixed breed dog, male neutered, comes with the acute history of cough and exercise intolerance. On physical examination, we can hear crackling lung sounds, mostly cranial part and mostly on the right side. So definitely we ask for thoracic radiograph. Now we got the thoracic radiograph here, right? So this is the thoracic radiograph of the dog that came with the coughing and exercise intolerance. So this is the one view. I think this is the right lateral view. This is the X-ray. Now you can see. I'll get you see again and again. So, and this is the left lateral X-ray. Now you can see, right? It will come again. And this is the ventrodorsal view. Okay. Based on your assessment of the radiograph, the thoracic body wall, we are talking about the body wall, thoracic body wall, right? Now we are not talking inside, we are talking about the outer part. So thoracic body wall is normal or abnormal? So yes, you can just message. I'll be happy to see engagement. Yes, it's normal. Thoracic body wall is normal in this X-ray, right? Now let's move further. So thoracic body wall, including extrathoracic structure, are within normal limits. So pleural space, we already discussed how pleural space looks like, how it should look. So the pleural space is, in this condition, normal or abnormal? So if we say pleural space is abnormal, we should be able to see pleural space actually. If we cannot see pleural space, that means it's normal. Normal pleural space is not visible. So now definitely there is no abnormal condition with the pleural space. So now let's talk about the heart. Based on the evaluation, cardiac structure, so we are able to see, for me, it looks normal, okay? There is no abnormal condition associated with the heart. The size also looks okay. And the margins, there is no bulging of the conditions, so it's normal. Heart also normal. So based on the assessment, the lungs, including the vessels. So now again, let's see lungs and vessels. There is a two different situation. Lung tissue, including vessel, is it normal or abnormal? So there is something wrong with the lung tissue and the supply and the vessel supply, right? So there is some pattern visible. Maybe I'll make it. So if you need to see, so you can see here and here, you can see. Okay. So here, now let's see. Definitely there is something wrong with the lung tissue and vessel supply. So now let's see this image. Here, unfortunately, I don't have that pointer here. Here you see this lateral. So there is an increased soft tissue opacity. Now I'm not saying bronchial, interstitial, vascular or anything. I'd say there is an increased soft tissue opacity mainly on the ventral aspect of the right cranial lung lobe. So from the lateral side, we may not be able to say right or left, but that we will say from the another view. Right cranial lung lobe. So right here there is an abnormal situation. Now I'll show you the another one. This is the one view. So now let's come here. There is an abnormal opacity, increased opacity. Right here there is an increased opacity. You can clearly see. Right here there is an increased opacity. And why I said right lung lobe, because we can say right easily in the ventrodorsal view. This is the right side. So now you can easily see, can you see? This part, this area of the lung lobe is having increased opacity. Now you can compare easily. You can compare this part with this part, this part, this part, and all the rest of the lung part. We can see. Now, as I mentioned earlier, this is called lobar sign. This is one lung lobe has severely affected. This right lung lobe is severely affected. You can see the lobe. Actually, what you have seen, this is the right cranial lung lobe. This up to here, right from right here up to all the way up to here. So this is the lobar sign. Now, and we'll see right here, if I make it more, अलि ठुलो देखिया छ है?
देखेछ sir.
Okay, that's good. So now, right here, up to here we can see the vessels, but down here we have lost our vessel supply. Normally, vessels is wide branching, right? Vessel supply means wide branching. Now we have lost our vessel supply, and now we can see there is a black branching. If we see very minutely here, I'll make it bigger. See, no vessel supply here. If you remember the earlier images, what I showed earlier, that there is a one vessel up, one vessel down, and in between bronchus supply. Now here, bronchus you can see, this is the bronchus, this black all the way up to here, this black all the way up to here, and again here branching, again here branching, another branch. So now we can see the bronchus, but there is no supporting vessel supply on the wall of the bronchus. So that means it's all white. Now down here it's getting more white. So now if we really see minutely, this is like we have seen black branching extending towards the periphery. Normally, in normal vessel supply, it's a white branching going towards the periphery. But here we have seen black branching going towards the periphery. One is this here, and even here you can see this is So this is what? This is what is this black branching? We discussed. This is called ear bronchogram. And this is right here we have seen, well, it's like a collapsed long lobe. You see, this we call it the lobar sign. One lobe is easily, we can distinct one lobe from the another lobe easily. That is called lobar sign. So from these findings, we can easily say this is alveolar pattern. Yes, from here, this we can easily say. So what we identified, there is no defined vessels. So vessels definition is gone. Ear bronchogram is visible. Lobar sign is visible. And the border also easily visible. And there is a what we call the opacity of the heart and the surrounding tissue also almost looks like the same, disturbing the border of the heart. So these all are suggestive of alveolar pattern. But we have to remember that in alveolar pattern, it's not necessary that all the features are there. Lobar sign, ear bronchogram, and in identification of the blood vessel, everything may not be there, but lobar sign may not be there all the time. But two things we always need to look for is ear bronchogram and loss of vessel architecture. So these two are very important. So finally, this is a alveolar pattern. Now let's go. So now we can clearly see ear bronchogram is there and the lobar sign is there, and the border you can see there is a loss of border of the heart. The heart border is not clearly identified, and the vessels also are not visible. Then from this finding we can see alveolar pattern. That means alveoli, the alveolus of this cranial long lobe is having issue, right? So what may be the conclusion? What may be the diagnosis? So our diagnosis includes increased soft tissue pulmonary opacity with the right cranial long lobe, with the presence of in identification of the pulmonary vessels, ear bronchogram, lobar sign, and the loss of border, lobar opacification with a cardiac silhouette. This represent alveolar pulmonary pattern, which is in this case is mainly ventral. So what may be the diagnosis? Ventral part ma cha, cranioventral part ma cha, alveolar pattern cha. Diagnosis ke huna sakcha? Because this is really a pathognomic. When we consider the location, this is really pathognomic. So I saw some positive comments. So this is a clear indication of aspiration pneumonia, because why we can say that there is a location, a specific location, right? Specific location means craniocaudal long lobe. That means when the dog gets aspirated, considering the gravity, it goes downwards. When we see the same pattern on the dorsal long lobe, then the diagnosis will be different. So it is ventral. That means first thing, the aspiration gets collected in cranioventral long lobe. Once it is aspirated, the collection starts first in cranioventral long lobe. So that's why we can put the aspiration pneumonia on the top of the differential. I'm not saying 100%, but this is almost 100%. But the top of the differential will come aspiration pneumonia. When we see lobar sign, air bronchogram, and loss of vessel identification, and the cranio ventral lung lobe, the first thing we have to consider is aspiration pneumonia. So yeah, we already discussed. So cardiogenic pulmonary edema mostly we see where? Caudodorsal lung lobe. Aspiration pneumonia we mostly see on cranioventral lung lobe. So cardiogenic edema we'll see on, as we have this the circle. Yes, right. We see right, that is most common, because that comes first. That bronchus supply comes first, and after the second supply comes later. So this is this is caudodorsal lung lobe. Mostly we see heart-related edema. We'll see in the caudodorsal lung lobe. And atelectasis may have lobar sign, but not all the signs that is supporting our aspiration diagnosis. So yeah, we discussed all patterns and we discussed on one particular case. Now let's discuss a little bit on some other structure. So we are almost finishing. Let's wrap up with the heart. This is a commonly used condition. In case of heart enlargement, cardiomegaly situation, we normally, this is the common method that we evaluate the size of the heart. So here you can easily see heart. So first we take the measurement from the carina all the way down to the apex, and in the middle of the heart, little bit up this area, we take the direct measurement. And these two measurement, we start from T4 all the way up to down here. And again, these two measurements. So we take measurement from here to here, and we put it here from T4 up to here. And this is another side. Again, we start from here and we start counting. 1, 2, 3, 4, 5, 6. For the red line, 6. Again for the blue, 6, 7, 8, 9, 10. Not 11, but little bit more than 10.5. So we concluded vertebral heart score 10.7. So this is how we do the measurement. We take two measurement and we start measuring from T4 vertebra, and we call that as a vertebral heart score, and we give the number. Now there's different numbers. Normally, if we say in general, so if you look all the numbers here, if sometimes in some dogs, let's say this Dachshund and Pugs and all, they naturally have little bigger heart. In normal other dogs, if it's like we say 9 to 10, 11, so that is a rough understanding, but they have different range for different dogs. यसमा के क्वेशन छ यो फेरि पछि आएन भने हुन्छ सोध्दा हुन्छ है हार्ट स्कोर कसरी लिने बुझ्यो नि हैन
बुझ्यो सर
हामीले खाली नाप्ने मात्रै हो दुईटा सेक्सनमा नाप्ने अनि त्यो भित्र कतिवटा भर्टिब्रा पर्छ 10 वटा पर्छ कि 11 वटा पर्छ कि अब 12 वटा पर्यो भने इट्स अब त्यसको लागि हामीले रेफरेन्स रेन्जै हेर्नु परेन क्लियरली हामीले इट्स कार्डियोमेगाली भन्न मिल्यो हैन अब कहिलेकाहीँ अलिकति ब्रिड वाइज चाहिँ लिटल डिफरेन्ट हुन सक्छ त्यसले गर्दाखेरि
मिटिङमा छु
के छैन है यसमा केही क्वेसन छ हार्टकोमा किन भन्दाखेरि यो पछि नआउन सक्छ यो यसमा खाली मेजरमेन्ट मात्रै छ यसमा केही पनि छैन यो चाहिँ मेजरमेन्ट यो अब उहरू पाइहाल्छ अब त्यो अर्को भनेको एउटा क्वेसन आएको छ ट्र्याकिया डिस्प्लेसमेन्ट त्यस्तो धेरै डिस्प्लेस छैन तर कौडल भेना काभा देखिएन कौडल भेना काभा यो रिजनमा यहाँ देखिरहेको छ है ठ्याक्क यो रिजनमा हेर्ने ठ्याक्क हार्टको बीच भन्नाले सेन्टरमा त हैन अलिकति माथिबाट ठ्याक्क डायफ्राग्मतिर यो रिजनमा हेर्नु पर्यो र कहिलेकाहीँ कौडल भेना काभा किन देखिन्न भन्दाखेरि हामीले इन्स्पिरेसन भएको बेला एक्सरे लिन्छौँ भने त्यो बेलामा त्यो चाहिँ हराउन सक्छ त्यो भएर के अरे एक्सपिरेसन गरेको बेलामा त्यो भएर फुल्ली एक्सटेन्डेड लङ चाहिँ हुनुपर्छ र हामीले एक्सरे लिँदाखेरि डगले कसरी ब्रिथ फुल्ली एक्सटेन्डेड लङ्समा लिन सक्यो भने इट्स भेरी गुड एक्सरे हामीले त्यहाँको सप्लाईहरू ब्लड भेसलहरू सबै चाहिँ के हुन्छ एकदमै क्लियरली देख्न सकिन्छ है सो अब अहिलेसम्म हामीले प्लुरल स्पेसको बारेमा पढ्यौँ तर प्लुरल स्पेस कतै पनि देखिएन हैन अब नर्मल कसरी भन्ने अब यो कन्फ्युजन हुन सक्छ सो एट द एन्ड आई लाइक टु show you one image so this is now we are seeing pleural space है तर अब देखिएको छैन तर इट्स अ प्लुरल स्पेस यहाँनिर अब यहाँनिर हामीले क्लियरली के बुझ्नु पर्यो भन्दाखेरि सर्टेन कुरा हुन्छ देख्दा त इजिली देखिन्छ अब यो लङ लोबहरु यहाँनिर के छ यो भनेको लङ लोब हो यो लङ लोब पहिला यहाँसम्म बस्थ्यो भने अहिले लङ लोब माथि पुगिसक्यो यो पनि लङ लोब हो यो पनि लङ लोब यहाँ फिसर लाइन भन्छौँ लोबार साइन भन्छौँ हामी के अरे लोबार डिफ्रेन्सिएसन भन्छौँ यहाँनिर लङ लोब क्लियरली छुट्टिरहेको छ यो लङ लोब यता छुट्टिया छ यहाँनिर एउटा लङ लोब यहाँनिर छुट्टिसक्यो अर्को लङ लोबको मार्जिन यहाँनिर छ भन्नुको मतलब हामीले देखेको यो पार्ट छ यो चेस्टको पार्ट अब हामीले यो लङ्स यति मात्रै हो किन भन्दाखेरि रिट्र्याक्सन भएर गइसक्यो किन रिट्र्याक्सन भएर गयो त भित्रतिर भन्दाखेरि प्लुरल स्पेसमा फ्लुइड जम्यो यहाँ यो अब यो चाहिँ प्लुरल स्पेस हो यहाँनिर नर्मल लङ एक्सरेमा प्लुरल स्पेस देखिँदैन अब यहाँ के भयो त फ्लुइड एकुमुलेसन भएपछि के गर्ने भयो त्यो फ्लुइडले लङलाई भित्रतिर पुश गर्ने भयो त्यो भएर हामीले यसलाई के भन्छ भन्दाखेरि रिट्र्याक्सन अफ लङ लोब्स अवे फ्रम द स्टर्नम यस्तो फाइन्डिङलाई के भन्छ रिट्र्याक्सन र बाँकी जति पनि स्पेस छ यहाँनिर के छ फ्लुइड हो यो जति पनि यो व्हाइट एरिया छ यो सबै फ्लुइड हो र यो लङ्स भनेको यति मात्रै हो यो माथि जति पनि ब्ल्याक देखिरहेको छ हामीले लङ्स चाहिँ खुम्चिएर माथि गयो तल के भयो त फ्लुइड जम्यो त्यो भएर यो भनेको एकदमै प्याथोगोनोमिक फाइन्डिङ अफ प्लुरल इफ्युजन यस्तो भयो भने हामीहरूले के त अब ड्रेन गर्ने हो कि अरू मेडिसिनल अप्सनमा जाने हो त्यो चाहिँ उ गर्नु पर्यो र अब at the end I would like everyone to take some tips at home. Never take only one view. Consider sedation if animal is not cooperative. Movement भएको एक्सरे राम्रो हुँदैन स्पेशली चेस्ट एक्सरे लेभल इज एक्सट्रिमली इम्पोर्टेन्ट राइट लेफ्ट एकदमै इम्पोर्टेन्ट हुन्छ त्यो लेभल गर्नुपर्छ अलवेज इभ्यालुएट विथ हेड अन लेफ्ट साइड हामीले इभ्यालुएट गर्दाखेरि हाम्रो लेफ्ट साइडमा एनिमलको हेड राखेर त्यो एउटा प्याटर्नमा इभ्यालुएट गर्नुपर्ने हुन्छ अलवेज इभ्यालुएट विथ द राइट साइड अफ द एनिमल अन लेफ्ट साइड भिडी भ्यू लिँदाखेरि के हुन्छ त भिडी भ्यू लिएको बेलामा राइट चाहिँ हाम्रो लेफ्ट साइडमा राखेर इभ्यालुएट गर्नुपर्छ अलवेज कन्सिडर एक्सटेन्डेड नेक position, right? Positive as a position. We already saw how it looked very different. And X-ray evaluation must be carried out in dark room. उज्यालो ठाउँमा हामीले इभ्यालुएट गर्न खोज्यो भने चाहिँ राम्रो इभ्यालुएसन हुँदैन. So I hope it was not a boring lecture. I tried my best to give, but this is supposed to be more interactive presentation. Due to the technical difficulty, I couldn't have much interaction, but still I hope you got good understanding of thoracic X-ray, and I hope this will help you to uplift your knowledge in future. So thank you for your attention. Thank you, everyone.